Cystic fibrosis is an abnormal mucus secretion and obstruction. So there's changes in the characteristics of the mucus. Instead of it being thin and free-flowing, it's very thick and clumpy. This happens because there's a mutated gene on chromosome 7. And this chromosome 7 is also responsible for sodium and chloride channels of the skin. Hence, as we're going to discuss, that's why a sweat test is used to diagnose. So these mucus glands produce a thick mucoprotein that accumulates and dilates them instead of forming that thin, freely flowing secretion. So the small passages in the pancreas and in the bronchioles and in other areas of the body, they become obstructed with these secretions. It's an autosomal recessive trait. So if both parents have the gene, the child has a 25% chance of getting it. And the median survival rate is about 32 years of age. This is a non-curable disease. It's the most common cause of chronic lung disease in children and young adults, and it's the most common fatal hereditary disorder affecting Caucasians. And basically it affects all the body organ systems because of this thick mucus that obstructs. So let's look at what does it affect. So again, it affects the GI system, the pancreas, the respiratory tract, the liver, and even reproduction. So it's an autosomal recessive trait. I'm going to look at that box again. You have the big C up here, meaning they have a trait, and the big C here, meaning they have the trait. And if they get a trait from both parents, then they have the disease. If they get the trait from one parent, as such the case here and here, then they have the trait, and they could just avoid it altogether and be free of trait or disease. So again, it's mutated gene on chromosome 7, and we diagnose it on infant metabolic screening test by DNA. And we do a sweat chloride of greater than 60 is considered a positive diagnostic tool. So again, because there's chromosome 7 is responsible for the sodium chloride channels of the skin, that's why the sweat test is helpful in diagnosing cystic fibrosis. So looking at clinical manifestations, one of the earliest clinical manifestations that we see is a meconium ileus. In some infants, we can diagnose cystic fibrosis at birth because of the severe bowel obstruction at meconium ileus. So it's an intestinal plugging by thick, tenacious secretions. More commonly, CF is diagnosed during infancy or toddlerhood, and that's because they have children have poor growth, and they have these bulky, greasy stools, and they get frequent infections like colds and pneumonia. So intersusception, and they get failure to thrive because they're not being able to absorb the nutrients. There's decreased absorption of the nutrients through the intestines because the intestines are coated with this thick mucus. So like I said, most of the time they get diagnosed a little bit later in infancy or in toddlerhood when they start having true failure to thrive. They get the stenorrhea, which is those fatty stools, that increased risk of diabetes because of the decreased release of insulin. And obviously the respiratory system is greatly affected. They can get clogged alveoli, which can cause emphysema. They have difficulty breathing because of the thick mucus, and that increased work of breathing makes them have an increased metabolic rate. They can get pneumonia. The liver can get clogged off, causing Clogged hepatic ducts causes the cirrhosis and eventually portal hypertension. In reproduction, they have decreased or no fertility. So how do we treat? These patients need pancreatic enzymes with every meal. So they have a huge appetite, but they can't gain weight because they're not absorbing those nutrients, they're not able to break down and absorb fat, and they have this increased metabolic rate. So because of this increased work of breathing, because of the malabsorption, they have this high calorie demand. So they need high calorie, high protein diets. Sometimes they need supplemental TPN, but regardless, they need these pancreatic enzymes with every meal. And that's adjusted to their stools. So you get less enzymes with loose stools and more enzymes with constipation. So if they're getting clogged up, we know that we're not controlling the secretions because they're getting constipated. They're getting, blocked up. So we need to increase their enzymes. And if they're having loose stools, that means we're giving too much. We're loosening it too much. So we need to decrease the enzymes. So we want to keep these enzymes as low as possible. So we're constantly monitoring their bowel habits to see. Like we talked about, they need ADEK, those fat supplements, the vitamins that are fat absorbed. They need high protein, high calorie. Respiratory tract. So the big cause of lung damage is because they get airway obstruction. So our treatment is aimed at that. So our treatment's all aimed at mobilizing those secretions. So we can decrease the number of bacteria and therefore hopefully decrease the number of infections. So that CPT is one of the most important approaches to helping improve lung function. It's performed several times a day, and it can be done by hand, like the cupping that you see on the chest. Oftentimes they have vests that they wear, and it just kind of beats on their chest, and that helps loosen those secretions so that they can move them into the larger airways so that they don't block the smaller airways. I apologize. They can use aerosols such as bronchodilators. They can use mucolytics, anti-inflammatory agents are all also used in conjunction with CPT. Again, that increased metabolic rate, they need high calorie diet. If they do develop infections, we need to treat them efficiently and effectively with the correct antibiotics. We encourage aerobic exercise to relieve congestion. And fertility, these patients often aren't able to have children, so they have to have open discussions with teens regarding that. So nursing care management for a patient with cystic fibrosis, assessment is key. We want to focus on the newborn, their feeding, how they're stooling, their pulmonary system, how are their lung sounds, what is their cough like, do they have any decreased activity or fatigue, and then their GI system, how do their stools look, is there any abdominal distension, are they having any growth failure or weight loss. Hospital care, again, the aerosol therapy, like pulmazine to decrease the viscosity of the mucus. CPT, again, is key for these patients so that they can loosen up those secretions and move them into larger airways. Supplemental O2 as needed, but we want to use this cautiously because sometimes these patients can retain CO2 chronically. Nutritional support, again, the high protein, high calorie, the fat soluble vitamins like ADEK, good IV access, emotional support, making sure that these patients are compliant with their medications. Oftentimes they're kind of angry with the raw deal they've been given, and they aren't very compliant. So, educating the family, helping with compliance is important. We talked about increased activity as much as possible. Bone health is important for them. Sometimes if they use steroids a lot, they can get bone density decreased because of chronic steroid use. So we looked at kids. How are elderly different? What are some AP differences in the elderly? They have an increased AP diameter, so they can have that barrel chest. Their cartilage is rigid. Things don't move. They have decreased elasticity, so they don't move as well. Their defense mechanisms are decreased. They have loss of cilia. They have a decreased gag or cough, so they're at higher risk for aspiration. There's decreased gas exchange. They have a blunted response to hypoxemia and hypercapnia. So the body is slow to increase that respiratory rate. So when they start getting high levels of CO2, we should breathe faster to kind of blow off the CO2. And the elderly are slow to do this. And they have decreased responses to the acid-base imbalance. So when they have acidosis or alkalosis, they should increase or decrease their respiratory rate to kind of blow off. And they don't. They're slower to do this. And they can have decreased O2 saturations. So lung cancer, it's the leading cause of cancer related to deaths. Most are over the age of 15, and there's an increased incidence in females. Smoking is responsible for 80 to 90% of lung cancer. And then there's environmental tobacco smoke, ETS, which is like your secondhand smoke, increases the risk by 35%. And children are more vulnerable, so we need to be careful about not smoking around cancer. So female smokers have the highest risk of developing lung cancers. Other cancers are like inhaled carcinogens, like if there's a miner, they work in a chemical manufacturing, or even asbestos. So lung cancer is a change in the bronchial epithelia related to a total exposure of the cigarettes. And we can have mets to the brain, bone, liver, and adrenals. So again, smoking 80 to 90%. And the clinical manifestations, many are due to this bronchial obstruction. If you want to look in Lewis on page 580, I believe, there's clinical manifestations listed. They can have cough, blood in the sputum, chest pain, dyspnea, wheeze, anorexia, fatigue, weight loss, nausea and vomiting, hoarseness. So there are two subtypes of lung cancer. There's non-small cell lung cancer, which accounts for about 80% of all cases. And there's small cell lung cancer, which is only about 20%, which is good because this is the more aggressive form of lung cancer and it has a worse prognosis. We diagnose it by history and physical exam, chest x-ray, CT scans, MRI, a PET scan, sputum or bronch, and we stage it according to TNM. So T is for tumor. It's staged by the size, the location, how invasive it is. N is for regional lymph node involvement, and M is for the presence or absence of mets. So again, diagnosed by H&P, chest x-ray, CT, MRI, PET scan, bronch, and it's staged by T for tumor, N for nodes, and M for Mets. And there's the difference between non-small cell and small cell lung cancer. So how are we going to treat these patients? They require surgery to remove the tumor if possible. So they can be done multiple ways. It's a surgical resection. They can do it by doing a total pneumoectomy, which is removal of the lung. They can do a lobectomy, which is remove a portion of the lung. Or they can do a lung conserving resection, where they just remove the cancer part. And this is the best chance of a cure. And these are the treatments of choice for the non-small cell lung cancer. Some require radiation and resection. And it's important to educate these patients on some of the radiation complications. Now radiation is just focused from the outside and radiates, from the outside onto the part of the body where the tumor is located. And it's used to relieve symptoms of dyspnea and the coughing up of the blood from obstructive tumors. But because of this radiation specific to one area, they can oftentimes get esophagitis, or they get a lot of skin irritation to the treatment field. So helping the helping the patients protect that area that's getting radiated and treating afterwards is very important. Chemotherapy is helpful because there's the radiation and complications. I apologize. Chemotherapy is helpful because it inhibits cancer cell growth. It does not directly kill the cells. We want to teach, health promotion as much as possible, educate them on signs and symptoms to report any worsening of the dysphagia or chest pain or hoarseness. Lots of emotional support, pain management, and all the treatment side effects that we talked about. Laryngeal cancer is cancer of the larynx. It's uncommon and often occurs after prolonged tobacco and alcohol use, and it has very few early symptoms. Now remember, the larynx is the voice box, and it protects the trachea against food and aspiration. It includes the epiglottis, glottis, and subglottis. So typically caused from prolonged tobacco alcohol use. Some clinical manifestations: hoarseness, right? It's the voice box, so their voice is not great. Lump, they can feel a lump. Voice changes, pain, dysphagia. They're diagnosed by laryngoscope, CT, MRI, or PET scan. And they're staged just like lung cancer by the T and M. Treatment. Treatment needs to be the patient's choice because, one, there's chemotherapy. There's radiation. But they can also have a radical neck surgery. This is where the larynx is completely removed and the windpipe is diverted. It's diverted here. So they completely remove that, divert the windpipe to here and brought to the surface. So they can still eat, it goes to the esophagus, but the windpipe no longer comes up. It's completely taken out. Again, this is a really big surgery, and Patients need to be educated. They're going to have to go through voice rehab with this. They need to be educated on good stoma care. They need to be able to have other ways to communicate, because until they go through voice rehab, they're not going to be able to communicate with you. So you need to make sure these patients can read and write so that they can communicate back and forth with people. Even things like if the patient needs to be bagged, that you have to be careful that you can't bag the mouth, because you're not going to be sending any air. You'll actually just pump the stomach full of air. You have to bag their stoma. They may need an NG or G tube initially, because they may have to relearn how to swallow and how to function. Suctioning, this is one of your skills, check off, and it is something we're going to review. Again, remember that when you're going to connect the tubing to, connect the catheter tubing to the suction machine, and you want to keep the end of the catheter sterile, clean, because you're going to be sticking this inside the body. You insert the catheter the proper distance, and then as you pull back, you're going to intermittently suction. Remember, when you're suctioning them, they can't breathe. So if you sit there and just apply continuous suction, you're taking their breath away from them. So intermittent suction every 5 to 10 seconds, and then they can repeat as needed. We're going to do all the things that we do, like we talked about with their skills checkoff. You're going to monitor their O2 throughout the entire procedure, make sure that they're not coming down too much. And they may need to be hyperventilated prior to. So there's the pictures, the radical neck, and the suctioning. Make sure you review your skills checkoff. Talked about no bag mouth, patient's nutrition, patient choice, and then review suctioning. Tuberculosis. So tuberculosis is called by Mycobacterium tuberculosis, and it's a chronic infection that damages tissue, lung tissue. It's highly contagious, and it's by direct contact or aerosol droplets. So let's see what's going on. So with tuberculosis, the bacillus is inhaled, and it right here, the bacillus is inhaled, and then it lodges into the bronchial and alveoli. From there, you get a local inflammatory reaction. So with the primary infection, you're going to develop antibodies, and at this point, diagnostically, you're going to have a positive PPD. Again, remember, positive is anything greater than 10. You might also see the local inflammation on chest x-ray and the positive sputum culture. Then there's the formation of the granuloma, where basically it walls off the infection and prevents the spread. And the majority of adults at this point is going to completely kill off TB. However, there might be some individuals where TB is latent. They're asymptomatic and they're unable to transmit at this time, but they do have a positive PPD because they've been exposed. Sometimes the immune system is stressed and they're unable to contain the TB, and you get active TB infection. And these symptoms develop typically 2 to 3 weeks after the infection or reactivation. So you can have primary TB, which occurs within the first 2 years of infection, or post-primary, which occurs 2 years after infection. So clinical manifestations, this has an insidious onset, meaning kind of a slow onset. Again, 2 to 3 weeks after the infection, they may present with flu-like symptoms with a cough. They might have some weight loss, some fatigue, night sweats, and usually a low-grade fever. And they have initial dry cough that becomes increasingly productive, and then they start coughing up blood, which is a late sign. These patients are treated with pharmacological agents. They typically are on a 4-drug regimen for the first 2 months, and then a 1 to 2 drug medicine regimen for 6 to 9 months. So as long as the patient is not drug resistant, we can be cured of TB as long as they take their medication properly for the extended period of time. It is important to educate these patients with the medications that we use to treat. They are hepatotoxic, so we need baseline LFTs and monthly LFTs to make sure we're not causing any liver damage. Rifampin, we need to educate them if they're on Coumadin. It may decrease the effects, and also rifampin decreases the effects of birth control. It's important to also educate these patients that rifampin causes orange secretions. So many times parents will come in because they're like, their pee is orange, or that they're crying orange tears. This is a normal side effect of rifampin, but it can be scary for the parents, so we do need to educate them. These patients need proper rest and nutrition to help fight infection. We need to make sure that we're isolating them appropriately during active infection, because this is spread through droplet. Outpatient care, remember that compliance is very important. As long as they are compliant with their medication, this can be cured. But drug resistance is very high because, as we said, if they're typically on medications for almost a full year to treat. So if needed, these patients often undergo direct observed therapy, where an RN provides meds and watches them to take them. We're going to get daily temperatures and weights, limit close contacts for several weeks, approximately 2 weeks, and make sure that they're disposing of their tissues properly. So INH and rifampin, ethylbutyl, isolation, compliance is a big issue. Monitor LFTs, education, decrease effects of birth control and Coumadin, and cause orange urine secretions. Bacterial pneumonia. This is an acute inflammation of lung parenchyma caused by a microbial organism. It can be community acquired or hospital acquired. Hospital acquired typically occurs 48 hours after admission. Some predisposing factors: if they have decreased loss of level of consciousness, if they have decreased cough, if they're smokers, if they're diabetic, if they're malnourished and they can't fight off infections, if they aspirate. Those are all things that puts the patient at higher risk for bacterial pneumonia. The patient acquires the organism by either aspirating it, inhaling it, or hematogenous spread. Basically, there's a primary infection somewhere else in the body, and it spreads to the lungs. So let's look at bacterial pneumonia. So again, it's an inflammatory response in the lungs, and it causes bronchoconstriction because we don't want to have any more invasion of foreign organisms, increased capillary permeability because we want to get mediators to that site, but then that causes fluid and debris in the alveoli, and if there's fluid in the alveoli, they can't exchange gases, the CO2 and O2, and that causes hypoxia. And then there's also increased mucus production because they want to trap those invading organisms. So it can be aspiration, inhalation. CAP versus HAP, community acquired versus hospital acquired. And we diagnose it by sputum. We're looking for gram stain in culture. On chest x-ray, we can see the whited out, the fluid in the lungs. CBC, the white count will show a high white count, which indicates infection. Pulse ox, they might have a low pulse ox. ABGs show the metabolic status and how the patient's responding. In clinical manifestations, they often get wheezing, they can get rhonchi, crackles, decreased breath sounds, use of the accessory muscles because of this bronchoconstriction. They're having to work really hard to breathe because they're having decreased gas exchange. So they got tachypnic, they have dyspnea, they get tachycardic. And they have this cough because they have this increased mucus production that's going to trap organisms, and they're trying to cough them out. They can also have systemic symptoms, such as nausea and vomiting. They can have headaches, mood swings, high fever, chills. So how are we going to treat these patients? Well, with cough, we want to do CPT, chest physiotherapy. Tell them to deep breathe and cough. Increase fluids because this helps thin the mucus. We can give expectorants, antitussives, mucolytics. Antibiotics help treat the infection. Bronchodilators will help relax those smooth muscles and open up, so decreases the wheezing. These patients need lots of rest because, again, we don't want to increase their oxygen needs, because if we increase their oxygen needs, then the patient has to work harder to breathe, and they're already having dyspnea. Things that we can do, like for aspiration, we can put the head of the bed up. Hypoxia, we can give oxygen and encourage them to use their incentive spirometer. And the way we prevent this is with the pneumococcal vaccine. This vaccine is normally given at about 65 years of age, at 65 years of age. If it's given prior to 65, they typically need a booster 5 years after the initial. All right, we have chronic bronchitis, COPD. COPD, which encompasses chronic bronchitis and emphysema. So COPD is a obstruction of the airway, which leads to destruction of the airspace. It's a chronic inflammatory response of the airways. And like I said, it encompasses two disease processes: the chronic bronchitis, which causes a persistent cough, and the emphysema, which causes the enlarged alveoli. So let's look at COPD. You have chronic bronchitis, which causes hyperplasia of the cells lining the airways, increased mucus production, and it kills off the cilia. On the other side, you have emphysema, which is killing off the layer that produces surfactant. Remember, surfactant is what helps keep that alveoli open and flexible. So if they don't have the surfactant, this alveoli become inflexible. And if they're inflexible, they're not able to exchange the CO2 and O2. And they develop over time a low BMI because of how hard they're working to breathe. So most of the time it's caused by smoking. It can also be environmental causes. Again, emphysema is that hyperinflation of the alveoli narrowed airways, and air trapping. So they get this progressive dyspnea. It gets harder and harder and harder for them to breathe. And because they're trying to keep the alveoli open, they prolong their expiratory phase of respiration. And with that, they have wheezing and decreased breath sounds. So they get this barrel chest that you see right here. They're using accessory muscles. You can see the retractions. They purse lip breathe. They kind of put their lips together and slowly force the air out. And that's going to help keep the alveoli open as much as possible to help as much gas exchange as possible. They tripod, where they sit forward with their hands on their knees or in between their legs. And you can see clubbing of the fingernails, and they tend to be very thin. So the alveoli become inflexible, which causes the barrel chest. They get these permanently popped open alveoli, and they do the pursed lip breathing. So it's PEEP to open the alveoli. And with the impaired gas exchange, they get low O2, which causes hypoxia, which can cause confusion, right? Because the first clinical manifestation we see from decreased oxygen is mental status changes. They tire easily because they're not getting enough oxygen to the tissues. So how do we treat? We give them oxygen, but be careful. They need, because of the increased calorie demand, they need a high calorie, high protein diet. They need good fluids. They need to, because they tire easily, they need to rest before they're eating so that they can get as much nutrition as possible during their meals. If they do a big activity right before they eat, they're going to be too tired to finish their meal, and they're not going to get the calories they need. They may also need a bronchodilator to decrease any bronchoconstriction. These patients have very little to none sputum and very minimal cough. Because it's not about the mucus production with emphysema. With emphysema, it's about the alveoli becoming inflexible. And because of that, they can't, remember, the alveoli sit up against the capillaries, and that's where that gas exchange occurs. But when they become inflexible, that gas exchange can't occur. And we really need to educate these patients on smoking cessation. So part of COPD, the other part with emphysema, is the chronic bronchitis. So this is chronic inflammatory changes and narrowing of small airways. With chronic bronchitis, you get a hypersecretion of mucus. So you get this hyperplasia of cells, so the diameter of the airway is narrowed. You get this increased mucus production, and cilia is being killed off. So they get this chronic productive cough that's most often in the morning and during winter. And you can diagnose if they have this cough for at least 3 months of the year for at least 2 consecutive years. And it's exacerbated by any respiratory irritants like cold, damp air. These patients get dyspnea because their airways are smaller. It's harder to breathe. Again, they get this chronic productive cough because of all the increased mucus production. And we need to check for signs and symptoms of heart failure because they have this increased work of breathing. They're short of breath. They are chronically having low O2 situations, and their bodies develops a polycythemia, right? Because the bone marrow is trying to increase the production of immature red blood cells to try to carry more oxygen to the body, so they get this ruddy appearance. They tend to have normal weight to be actually being heavy set, and that's because they often are retaining fluid. Another reason why we need to check for signs and symptoms of heart failure. So for the dyspnea, we can give bronchodilators. We can give both short and long acting. We can give mucolytics for the cough. And we diagnose this by H&P, pulmonary function test, chest x-ray, ABGs. Later stages of this disease will show low PO2 and elevated CO2. EKGs, we're checking for the right ventricle to see if there's any heart failure. Because of these lung changes, remember the right side pumps to the lungs. So if the right side is having to work because it can't pump because it's meeting too much resistance, it can fail. Exercise testing, echo. Again, checking for right and left heart ventricle failure. And sputum culture for culture and sensitivity. Exercise testing. So how are we going to treat these patients? We're going to avoid risk factors. Smoking cessation is key. Vaccination, the pneumococcal vaccine. Again, at age 65, or if they got it prior to 65, they get it 5 years later, a booster. We look at bronchodilators. These help relax smooth muscle and help reduce the dyspnea. We can give short-acting bronchodilators like albuterol or Atrovent, or long-acting like Ceravent. These patients are often in rehab because we want to prevent any disease progression and relieve the symptoms. We want to improve their exercise tolerance so that we can improve their quality of life. During exasperations, they might get inhaled corticosteroids. We don't like to use oral steroids. If there's an infection, we need to treat the infection with the proper antibiotics. They get long-term oxygen with humidification. This helps improve their exercise capacity and improve survival. But you have to identify complications of O2 therapy. So these patients become kind of dependent on their high CO2 levels. So their O2 drive is hypoxia. If we administer too much oxygen, we get concerned with knocking out their drive to breathe. So we need to titrate to the lowest effective dose. So we need oxygen to improve their exercise capacity, but we don't want to give them too much where it stops their drive to breathe. Surgical therapy, sometimes they can do that to reduce the size of diseased lung. RT and PT, they can, especially respiratory therapy, can help with breathing retraining, like the pursed lip breathing, which helps prolong that PEEP, keeps the alveoli open as much as possible. That pursed lip breathing, the CPT for those secretions, exercise training, and then nutritional therapy is really important, especially if they're more like the emphysema picture and low body mass. Weight loss, malnutrition is common for them. If they are developing signs and symptoms of heart failure, they might limit fluids and sodium. We typically divide their meals into 5 or 6 smaller meals per day because, again, we don't want them to tire out with a big meal. We want high calories, high protein, moderate carbohydrates, moderate high fat, and again, resting before eating, using bronchodilators, avoiding foods that cause lots of chewing. And last but not least is acute bronchitis. This is inflammation of the bronchi in the lower respiratory tract due to infection. Most of the time it's caused by a virus and it's self-limiting. We diagnose it by history and physical and chest x-ray. Clinical manifestations: fever, headache, malaise, shortness on breath on exertion, and cough. Cough is the most common symptom and can last 3 weeks. Treatment, again, it's self-limiting, so treatment is focused on symptomatic treatment. They get fluids, rest, bronchodilators, cough suppressants. And cough suppressants can include narcotics. These are the most effective, like codeine. This helps with the cough. We want to use the lowest dose possible. You can get dextromethorphan. Or Tessalon. And Tessalon's non-opiate. Side effects aren't common. And that's the end of your respiratory lecture. So if you have any questions or concern, remember that there is a Ask the Professor discussion board for each test. So go to test 3, and if you have any questions, don't hesitate to post something because you might have the same question as somebody else. And that's it. Have a great day.